Hello, my name is Kavya Bharathidasan, and I'm a first-year internal medicine resident at the Texas Tech University Health Science Center in Lubbock, Texas. Today, I'd like to present a case of mitochondrial myopathy mimicking Guillain-Barré syndrome in a 21-year-old graduate student. Mitochondrial myopathies occur in around 1 out of 5,000 people in the United States. Clinically, they can be classified into chronic progressive external ophthalmoplegia, skeletal muscle CNS syndromes, or pure myopathy. Cardiac abnormalities occur in around 1/3 of these patients, mostly in the form of cardiomyopathy or conduction abnormalities. We present a case of a 21-year-old male student who was referred from Student Health for a 3-week history of bilateral lower limb weakness, pain, and swelling. These symptoms began after he traveled to the United States from India. On examination, he had tachycardia, bilateral 2+ pitting edema up to his knees, 4 out of 5 MRC grade weakness and mild tenderness of his upper and lower extremities, including both proximal and distal muscle groups, absent deep tendon reflexes, foot drop, bilateral ptosis, and limited extraocular movements. His initial admission labs revealed elevated creatinine kinase, BNP, troponin, myoglobin, lactic acid, and a reduced serum bicarbonate. Due to a traumatic tap, though he had elevated CSF protein, these lumbar puncture results were unreliable. An ECG showed left axis deviation with left anterior fascicular block, and chest X-ray and CT angiography showed cardiomegaly and volume overload. His bedside echo revealed mild left global hypokinesis with reduced ejection fraction of 40 to 44%, along with mild pulmonary hypertension. Though we strongly suspected GBS due to his bilateral onset of progressive lower limb weakness and his areflexia, cardiac manifestations are quite uncommon in GBS. Due to declining maximal inspiratory pressures, the patient was admitted to the ICU and on ophthalmology consult confirmed ophthalmoparesis and ruled out cranial nerve palsy, myasthenia gravis, and retinitis pigmentosa. Our extensive autoimmune and infectious workup was non-contributory. Finally, a muscle biopsy from his rectus femoris revealed active and chronic primary mitochondrial myopathy. An endomyocardial biopsy revealed active lymphocytic myocarditis. The patient was successfully treated with furosemide, metoprolol, and methylprednisolone. On follow-up, he seemed to be doing much better. So myopathies should definitely be considered in the differential diagnosis in patients whom Guillain-Barré syndrome is suspected. Especially in this interesting case of myopathy with prominent cardiac manifestations, we reaffirmed through our review of literature that myositis presenting with myocarditis should raise suspicion for mitochondrial disease. On behalf of my co-authors, I thank you for taking the time to listen to this presentation today.